In this lecture we are going to study the branches of pharmacology. So let's get right into it. Branches of pharmacology. 1. Pharmacokinetics. Pharmacokinetics. Pharmaco, a drug. Kinetics, motion. Action of body on drug or how body handles drugs. Pharmacokinetics, ADME. Pharmacokinetics is characterized by 4 processes: absorption, distribution, metabolism, biotransformation, and excretion, elimination. It is important for us to note that for most substances or drugs, these processes proceed at a rate proportional to the concentration of the drug. This is because they follow the law of mass action. The law of mass action. It states that the rate of reaction is directly proportional to the active masses of reacting substances. For example, the transfer of molecules across cell membranes or formation of metabolites is high at high concentrations of a drug and vice versa. These processes are called first-order processes. Most drugs are subject to first-order processes of absorption, distribution, metabolism, and elimination. However, some drugs follow what is called rate-limited or dose-dependent or zero-order or saturation kinetics. In these processes, as the amount of drug in the body rises, those processes that have limited capacity become saturated, i.e. the rate of the process reaches a maximum at which it stays constant. This is usually due to limited amount of enzymes. Further increase in rate is impossible despite increase in dosage. Enzymes are usually finite and can become saturated, hence occur usually in enzyme-mediated metabolic reactions. For example, in alcohol metabolism, alcohol dehydrogenase gets saturated at concentrations of 10 mg per dl. Further intake of alcohol does not increase metabolism. During the processes of absorption, distribution, metabolism, and excretion, all the drugs have to cross cell membranes which are made of bilayers of phospholipids and globular proteins sandwiched in between them. Lipid-soluble substances diffuse rapidly into cells and therefore throughout the body tissues. Special protein molecules within the lipid bilayer allow specific substances to enter or leave the cell, preferentially carrier proteins. The passage of drugs across membranes is determined by the natural processes of glomerular filtration, carrier-mediated transport, and diffusion. Absorption. It is a process by which the drug leaves the site of administration to circulatory system. How drugs transfer from site of administration. 1. Filtration, aqueous diffusion, passage of drugs through aqueous pores. Size should be less than size of pore. Has to be water soluble. No plus glucose, caffeine. 2. Lipid diffusion / simple diffusion. Drugs supposed to pass through the membrane. Drugs must be lipid soluble. High partition coefficient, high absorption. 3. Carrier-mediated absorption. 8. Facilitated diffusion. Passive mediated diffusion but facilitated by proteins in the form of transmembrane channels, e.g. levodopa and amino acid into brain. B. Active transport. Use ATP and carrier proteins against the concentration gradient, e.g. levodopa and methyldopa from the gut. 4. Phagocytosis and pinocytosis. Process by which large molecules are engulfed by the cell membrane, forming a vesicle and releases them intracellular, e.g. protein, toxin. Routes of administration. 1. Enterolide. Oral, rectal, sublingual, buccal. 2. Parenterolide. Intramuscular, subcutaneous, intravenous, intra-arterial. 3. Inhalation. 4. Topical. Drug absorption of various types. Oral preparations. Liquids, elixirs, syrups which are fastest. Suspension solutions. Powders. Capsules. Tablets. Coated tablets. Enteric coated tablets which are slowest. Factors affecting GI absorption. 1. pH of media and pK of the drug. pH affects solubility in the gut. 2. Area of absorbing surface. 3. Particle size of the drug. 4. Formulation. 5. Gut motility. 6. Gut blood flow. 7. Gastric secretion. 8. Drug interaction. Factors that affect absorption. The duration and intensity of drug action is influenced by absorption, hence, the route of drug administration, dose, and the dosage form are vital considerations during absorption. The nature of the absorbing surface, i.e. cell membrane through which the drug must traverse, e.g. the ileum. Blood flow to the site of administration. Concepts that are closely associated with absorption. Enterohepatic circulation. This is circulation of drugs between liver and intestines. Bile salts circulate between the intestines and the liver 8 times a day, and some drugs follow the same route. Some drugs are hydrolyzed by help of enzymes/bacterial and are reabsorbed back and later reconjugated with glucuronic acid or any other endogenous compound. This process maintains the effects of some drug for a long time within the circulation, e.g. sulindac, litigioloestradiol, pentaerythritol, and tetranitrate. Presystemic, fast-pass elimination/effect. This means metabolism of drugs during a single pass through the gut wall and, usually, liver. This metabolism differs between drugs and between individuals. Fast-pass effects cause variation in the systematic drug concentration, hence drug response. Fast-pass effects influences bioavailability, plasma concentration, and therapeutic effect. Once a drug is in systemic circulation, irrespective of which route is used, about 20% is subject to the hepatic metabolism each circulation because that is the proportion of cardiac output that passes the liver. Not all drugs are seriously affected by this effect. Examples of those most affected include propranolol, metoprolol, pentazocine, and morphine. Oral drugs that undergo a lot of presystemic elimination are given at a higher dosage than parenteral route dosage. Some drugs undergo insignificant fast-pass effect, hence parenteral and enteral doses are comparable, e.g. phenytoin, theophylline, warfarin, diazepam, and chloramphenicol. Fast-pass effect. Routes that bypass the liver. 1. Sublingual. 2. Transdermal. 3. buccal. 4. Vaginal. 5. Rectal *. 6. Intramuscular. 7. Intravenous. 8. Subcutaneous. 9. Intranasal. 10. Inhalation. * rectal route undergoes a higher degree of fast-pass effects than the other routes listed. Bioavailability. Bioavailability, fraction of administered drug that reaches the systemic circulation and becomes available to the target tissues following administration. Amount of drug available in the circulation or site of action. Bioavailability is expressed in percentage. Bioavailability is 100% for drugs given for. Factors affecting bioavailability. Extent of absorption. Fast-pass effect. Different manufacturers, or the same, should aim at producing drugs with reliable or comparable bioavailability. This ensures therapeutic equivalence and subsequently equal therapeutic effectiveness. Process by which a drug reversibly leaves the bloodstream and enters the interstitial and/or cells of the tissues, ultimately its site of action. Factors affecting drug distribution. 1. Plasma protein binding. Albumin equals acidic drugs. Glycoprotein equals basic drugs. 2. Tissue uptake of drugs. Adipose tissue, DDT. Bone, TTC. Liver, chloroquine. Thyroid gland, iodine. 3. Barriers. Blood-brain barrier and placental barrier. 4. Rate of blood flow. Brain, kidney, liver and lung highly perfused. 5. Cardiac function, e.g. cardiac output and regional blood also influence distribution. Drugs are fast distributed to areas with the richest blood flow, e.g. heart, liver, kidney, brain, and later to those with poor blood supply, e.g. muscle, fat tissue. Volume of distribution. It is the volume of fluid in which the drug appears to distribute with a concentration equal to that in the plasma. Degree to which the drug is distributed to the tissues rather than in plasma. The drugs with a high lipid solubility, non-polar drugs, low rates of ionization or low plasma protein binding have higher volumes of distribution than drugs with opposite characteristics. Selective distribution occurs when drugs have special affinity for particular body constituents, e.g. chloroquine bind to melanin-containing tissue, e.g. retina, which may cause retinopathy. Iodine concentrate in thyroid when it's taken up into follicle cells by NOR+/iod transporter. Iodine is required for synthesis of thyroid hormone T4 or T3. Plasma protein binding. Drugs are widely distributed in body water, free fraction of drug, and partly as bound to plasma proteins and or to tissues. Plasma proteins binding and tissue binding are drug reservoirs that sustain pharmacological action of drugs. The bound fraction and the free fraction are usually in a state of equilibrium. Albumin is the main binding protein for drugs and other natural substances. Other proteins involved include lipoproteins, alpha-1 acidic glycoprotein, and globulins. Some proteins are more specific for certain drugs while others are not. Drug albumin molecule too large to diffuse through the blood vessels, hence it's trapped in bloodstream and subsequently it's pharmacologically inactive. It becomes circulating reservoir or storage depot. Albumin has a high affinity but low capacity for binding of acidic drugs and a low affinity but high capacity for binding of basic drugs, hence a lot of drugs are bound but readily released. As free drug is eliminated by metabolism, dialysis or excretion, it's replaced by drug released from the bound fraction. Those drugs that are tightly bound have longer duration of action than those that are loosely bound. Plasma protein binding may be influenced by hypoalbuminemia, which may result from liver problems like liver cirrhosis, hepatitis, and severe malnutrition. Free fraction of the drugs increase, hence toxicity is possible. The dosage of drugs to be administered should be reduced till normal plasma protein levels are achieved. Chronic renal failure may result to metabolites being retained and competing for binding sites with similar consequences above. Tissue binding. Adipose tissue and lipid-soluble drugs have high affinity for adipose tissue. The low blood flow to adipose tissue makes it a good reservoir for drugs, e.g. thiopental. Other drugs will bind to the bone, e.g. tetracycline is absorbed onto the bone crystal surface, hence interfere with skeletal tissue's development of fetuses. Teeth may also get discolored. Permanent teeth can also become discolored if the drug is given during the prenatal period or early childhood. Biological membranes which limit the distribution of drug. Blood-brain barrier allows distribution of only lipid-soluble drugs, e.g. general anesthetics, barbiturates, into the brain and CSF. Blood-brain barrier is made of a row of capillary endothelial cells joined continuously by tight intercellular junctions. Capillaries are covered by a fatty sheath of glial cells. Drugs that don't or slowly cross blood-brain barrier cannot be used to treat infections in the brain. The use of intrathecal, through the spinal canal or subarachnoid space administration avoids this barrier. Inflammation of the meninges, however, increases permeability of ionized drugs. Placental barrier, these are membranous layers that separate blood vessels of the mother from those of the fetus. Lipid-soluble and some lipid-insoluble substances can diffuse through it, hence some drugs meant for the mother may pass through the barrier to harm fetus. Examples of such drugs include steroids, narcotics, and anesthetics. Blood-testis barrier, this may limit the effectiveness of some chemotherapeutic agents used for treating testicular neoplasm. Biotransformation/metabolism. Alteration of drug structure which may result in 1. Inactivation. 2. Activation prodrug of the drug. 3. Activation from another active drug. Main site of biotransformation are liver, intestine, plasma, lung, and the skin. Metabolic processes change drugs in two major ways. 1. By reducing lipid solubility, which increases drug polarity. 2. By reducing the biological activity. Metabolites are generally more polar than parent compounds, hence the excretion rate is increased. Two phases of biotransformation. Phase 1 biotransformation, non-synthetic. It consists of reactions. Oxidation, ethanol. Reduction, estrone. Hydrolysis, procaine. The products are more reactive than parent drug. Purpose of phase A reaction is to introduce functional groups NH2, thiol, hydroxyl, OH, COOH, SH, chain 2, which serves as an active center for conjugation in phase 2 reactions. Examples of enzymes catalyzing these reactions include cytochrome P450 monooxygenase system, mixed function oxidase, aldehyde alcohol dehydrogenase, aldehyde dehydrogenase, and deaminase esterase, amidases, and epoxide hydratases. Phase 2 reaction, conjugation, synthetic. Conjugating compounds include glucuronide, CF, morphine, sulfonamide, EC. Acetyl, INH, hydralazine. Sulfate, steroids. Methyl, catecholamine. Enzymes used in phase 2 reaction. They include glucuronyl transferase, sulfotransferase, transacylase, acetylase, ethylases, methylases, glutathione transferase. These phase enzymes are in numerous tissues and plasma, e.g. subcellular locations, the cytosol, mitochondria and endoplasmic reticulum. Only those enzymes located in the endoplasmic reticulum are inducible by drug. Cytochrome P450 monooxygenase or mixed function oxidase. This enzyme system is primarily located in the liver where it plays central role in metabolism of drugs. A large variety of P450 exists. Each catalyzes the metabolism of a unique spectrum of drugs with some overlapping in the substrate specificities. Most of them are involved in phase A reactions. Enzymes responsible for metabolism of drugs. Microsomal enzymes. Present in the smooth endoplasmic reticulum of the liver, kidney, and gut. E.g. glucuronyl transferase, dehydrogenase, hydroxylase, CYP450, etc. Non-microsomal enzymes. Present in the cytoplasm, mitochondria of different organs. E.g. esterase, amylase, hydroxylase, etc. Enzyme induction. Phenobarbital, a non-selective. DDT induces CYP1A1. Enzyme inhibition. Cimetidine ketoconazole. Erythromycin chloramphenicol. Consequences of drug biotransformation. Activation, L-dopa dopamine. Maintenance of activity, diazepam oxazepam. Inactivation, phenobarbital hydroxypentobarbital. Factors influencing drug metabolism. Physiological factors like starvation, liver diseases, cardiovascular problem. This depresses microsomal enzyme systems. Age. People in extremes of age have decreased metabolism, e.g. very young people have immature enzyme systems while the elderly have degenerative enzyme function. Genetic predisposition. Genetically determined differences in the rate of metabolism of some drugs exist, e.g. isoniazid is metabolized by the acetyltransferase enzyme system. They portray the tendency for fast and slow acetylation which may lead to toxicity from metabolite and parent drug respectively. Prior administration of the particular drug or other drugs, e.g. repeated administration of a drug may cause induction or inhibition of microsomal enzyme. Enzyme induction and inhibition. Enzyme induction. This is a situation whereby there is an increase in amount and activity of liver microsomal enzymes actually due to exposure to certain substances such as drugs and endogenous substances. A drug may induce its own metabolism, metabolic tolerance, and that of other drugs catalyzed by the induced enzyme system. Enzyme induction. Enzyme induction is pharmacologically important because of the following reasons. Drug interactions may occur. For instance, anti-TB drugs may interact with oral contraceptives. 2. Diseases may result, e.g. anti-epileptic, increased breakdown of dietary and endogenous vitamin D which may lead to deficiency, osteomalacia. 3. Tolerance, metabolic, to the drug may occur. 4. Drug toxicity may result, e.g. a patient on rifampicin who becomes enzyme-induced is more prone to toxicity after paracetamol overdose because of faster production of hepatotoxic metabolites. Examples of drugs that induce liver enzymes include carbamazepine, griseofulvin, phenytoin, primidone, tobacco smoke, phenobarbital, isoniazid, macrolide antibiotics, and barbiturates. Enzyme inhibition. This refers to decreased synthesis and activity of liver microsomal enzymes. It results in reduced metabolism of other drugs / inhibiting drug and endogenous substances. Examples of drugs that inhibit enzymes include chloramphenicol and cimetidine. Pharmacokinetics. Half-life. The time it takes for 1/2 of the original amount of a drug in the body to be removed. A measure of the rate at which drugs are removed from the body. Excretion of drugs. Transportation of pharmacologically active or inactive metabolites out of the body. 1. Minor route of excretion. Eye, breast, skin. 2. Intermediate route. Lung, volatile. Bile, digoxin, rifampin. 3. Renal excretion, major route for most drugs and involves glomerular filtration, active tubular secretion, passive tubular reabsorption, renal elimination. This is the most important route of drug elimination. Drugs are excreted as unchanged or partially changed. Net renal excretion of drug is a result of 3 separate processes. I. Filtration, passive glomerular filtration. 2. Reabsorption. 3. Active tubular secretion. Passive glomerular filtration. Availability of drug for glomerular filtration depends on its plasma concentration in the unbound form. Protein-bound substances are too large to be filtered. Highly bound drugs are cleared slowly. Most drugs have a low molecular, less than 1000, hence freely filtered from plasma at the glomerulus. Glomerulus allow drug of molecular weight of less than 20,000. Approximately 20% of renal plasma flow is filtered through glomeruli, hence 80% pass on to proximal tubule. Tubular secretion. 2 transport systems secrete drugs into ultrafiltrate, one for organic acids and other for organic bases. It's an energy-dependent transport system because it moves drugs against concentration gradient. Both are non-selective, hence it's a potential site for interaction as drugs compete for transporters. Protein binding has no impact on tubular secretion because the affinity of the transporter system for most drugs is greater than the affinity to plasma protein binding. Since 80% of the drug delivered to the kidney is presented to the carrier molecules, tubular secretion is the most important/effective mechanism of renal elimination. Note that 100% of the drug, free or unbound, is available to the carrier molecules. This is not so for glomerular filtration, which only deals with the free fraction of the drug. Reabsorption. After filtration, most lipid-soluble substance is reabsorbed or slowly excreted. Those that are water-soluble are excreted more readily. The urine pH is 4.6 to 8.2. The pH of urine affects the amount of drugs reabsorbed in renal tubule by passive diffusion because passive diffusion depends on lipid solubility. Most drugs are either weak acids or weak bases. Hence, the change of urine pH changes ionization status of drugs and subsequently their lipid solubility. This ion trapping effect means that a basic drug is more rapidly excreted in acidic urine, ionization occurs, and acidic drugs are rapidly excreted in alkaline urine. This concept has some utility in treating poisoning from weak organic acids, e.g. aspirin or phenobarbital, whereby alkalizing urine can result to increased urinary secretion. Alkalinization is achieved by administering sodium bicarbonate or tromethamine (TM). Furthermore, high doses of vitamin C and ammonium chloride acidify urine and promote excretion of basic drugs. Intestine/biliary excretion. After metabolism in the liver, the metabolite is secreted into the bile and passed into duodenum, then eliminated into the feces. Some substances undergo enterohepatic recycling. These are later particularly excreted by the kidney. In the liver, just like in proximal tubule, there is active transport system for basic and acidic drug substances of molecular WT greater than 300 excreted in bile. Other drugs taken orally, e.g. neomycin, should act locally in gut and later they are eliminated in feces. Other substances may diffuse passively into the lumen of the gut from the blood. Such substances can be eliminated using activated charcoal which adsorbs them. Pulmonary elimination. Most of drugs eliminated by this route are usually intact and not metabolites. Usually gases and volatile liquids, general anesthetics, are administered and excreted through the same route. Increased cardiac output increases perfusion of the lungs, hence it increases drug elimination and vice versa. Ethanol is expired by this route, hence breath analyzers are used to regulate road regulations. Sweat and salivary elimination. This is a relatively insignificant route of elimination and depends on diffusion of lipid-soluble drugs through the epithelial cells of the glands. Elimination of drugs and metabolites into sweat may explain some side effects like dermatitis and photosensitivity. Those excreted via saliva are swallowed and undergo same fate as oral drugs. The intravenously administered drugs, once excreted through the saliva, may make one complain of a bad taste of the drug in the mouth. Breast/milk elimination. Many drugs cross epithelium of mammary glands and are excreted into breast milk. Breast milk is acidic, pH 6.5, hence basic drugs e.g. narcotics achieve high concentration in it while acidic drugs e.g. diuretics, barbiturates, sulfonamides etc. concentrate less in breast milk because they do not ionize in it. I want to stop there for now. Thank you for watching. I hope you found this video useful. Always stay tuned for more videos.